Thank you, Kostas. I think we have to move on to our final speaker, who is joining us from Barcelona. Dr. Lapuente will talk to us about Jett Plasma and explain what this is and how it works and what his experience with this method is that so far is little known within the Dry Eye Club. Dr. Lapuente, buenos días. Muchas gracias para presentar.
Bonjour. Thank you very much. I'm very grateful for this introduction, and thank you, Gert, and thank you all the board members of the EuDES for this kind invitation. For an outsider, the outsider that I am, that I'm bringing in some experience with this new topic, this new device, the Jett Plasma energy device in the treatment of the MGD. So here you have my disclosure. Let me go across without stopping on the multifactorial disease that the dry eye represents. And let's focus on the overlapping of the meibomian gland disease in this disease. So due to the high prevalence of the disease and the impact in surgeries like the multifocal intraocular lenses, and the unhappiness of the patients who have been underscored in relation with this type of disorders, we need to go back to the list of the physical methods. Some of them have been discussed, and it fits into this box. We have the plasma energy delivery alongside the other choices that have been described before. And as I received the suggestion of the title by Professor Gerling on this conference, and I got this subtitle, "What is that?" I was very pleased because I would not be in charge of facing the number of discussions that precede the IPL issue that we got in 2017, and we spent a number of months, even years, to fully explain, and now even reaching to a higher level of understanding after the conference delivered by Lisa. So let's go back to the pioneers here. Tesla reproduces in his lab a high voltage, short duration current with this nice picture figure here, like the lightning in the atmosphere. So that's the fourth state of the matter. That's the energy of the plasma. And what does it do? It does within the cells. It does an electroporation, which means pores or small drillings, micro drillings in the surface of the different cells. It can we can take advantage of this effect to bring into the cell, into the cytoplasm, some factors or molecules to induce transient transfections, or either approach it to get a more stable effects in the nucleus. That's for the future. So this new technology will open the doors to another type of treatments in the future. But nowadays, I'm talking about a method of delivering reversible electroporation, which means you deliver the energy, you get the micropulse, the cell reorganizes the current, the electrical charge within the walls of the membrane, and you get the benefit. And after the pulse is over, the cell regains and the micropulse disappear. While if you use an excess of energy, you get the cell death, and while you get the cell death, the apoptosis goes along with some other effects you might not want in this case, but those are the desired ones when you apply this type of energy in other previous indications in the cosmetic field and oculoplastics. So this is the platform that we use. It's a handheld device delivering plasma energy in the tip. It has two types of tips, as we are going to describe, but I need to warn you that probably you are going to see this new evolution of the machine. I haven't tested yet, but I've been told that it's much more powerful, which is going to be interesting for some applications in distichiasis and all the lashes issues. But here we are going to focus on the contact technique with a silver probe, which is intended for the mild and moderate treatment of the disease. While you have depicted at the right with eye globe protection the visible energy of the plasma when you have the non-contact probe. So, as a summary, and this is going to be a subject of future talks. How does it work? This was not a question that you asked us, but there is a thermal stimulation compound that's allowing to get rid of the plaque of the waxy secretion and easing the outflow of the mebum, stimulation of the collagen production, and as the last one, I need to mention the depolarization of the cellular membrane. This means that the cell is going to receive what I call an electroshock. And this is going to reorganize all the ions within the cell. And in the zeroing process, the cell will regain some of its electrical stability. Those are the claims, and this is one of the pictures and the motion provided by the manufacturer. Well, it didn't run, but nevertheless, the manufacturer took advantage of a previous and simultaneous experience on the histological effects in the vaginal and gynecological indications of the machine. So they got that the stimulation with this plasma resulted on a collagen production and elastic fibers increase, while supplementary vascularization and improvement of blood perfusion was achieved too. So with that evidence, collateral evidence, I would classify, we approach the treatment with a topical anesthetic, and for the eye itself, we use a gel in order to protect from the conductive gel that we use for the eyelid margin. We use it in 4 sessions, 1 week apart, and now we are comparing with 2 to 3 sessions if we can keep with the same effect. We spent 2 minutes per eyelid for all 4 eyelids, and we had a video here. I don't know if we can run it. Well, we can slip it across the eyelid margin, and then this is a mild to moderate category, and we are using energy levels of 5, up to 5. The patient is not uncomfortable at all. Some authors did approach the eyelid margin and then follow from the outer part of the eyelid, from the skin part. So, and some other authors, they prefer to stay to get the treatment inside the conjunctival, the tarsal conjunctiva. But the patient can tolerate up to 7, which is almost the maximum of the delivery of the machine. And you can see those little whitish bubbles that represent the flow of the electrons across the conductive gel. It's not debris from the eyelid. By the way, seen here, you can imagine that you have the benefit of the mechanical maneuver of the eyelid itself. And this is going to appear later on in the statistics. So here you have depicted the effect of the immediate effect of the non-contact technique in those cases that we need to approach just once. patients that we cannot follow up, or patients that need an emergency surgery. You can anesthetize whatever the method that you prefer, and you deliver with a non-contact probe the energy in the eyelid margin. You can see immediate shrinkage of some of the parts of the eyelid, and you would be astonished how beneficial regarding the reduction of inflammation this procedure is. So, um, back again, contactless techniques for more severe cases. This is a resource, an extra resource, and we are now dealing with a contact technique which is going to be repeated and is not uncomfortable and very well tolerated. Some early publications are now available by Zemanova, and most focused on the parameters of the TR film stability and breakup time. But now we decided, as we had to face a multicentric study that was carried out in the Czech Republic, using 50 treated patients and 25 controls, with a simple blind independent observer, with a control sham maneuver, which was making the same maneuvers over the eyelid margin over the same time, but without connecting the machine. And we had to define the principal, the main primary objective to be measured, and it needed to be very coherent in the multicentric study. So we decided to choose the EuDES score, and even recognizing that when you follow all the items, there are some of the items that are very sensitive to the season, and you can see, for instance, that air conditioning is season dependent, and some of them are depending on the type of the area and the climate that we have at that time. So we got the score, we put it into a template with some other data that we collected in the study, and at this moment, the study is yet to be accomplished within a couple of weeks, with the last cases in both groups at 12 weeks. But now we have seen the analysis in the treatment group with highly representative improvement regarding the pre-treatment status. While in the placebo group, we got an improvement, but it resulted to be much lower when compared to the one that we obtained with the connection of the plasma energy. So while we had a quite important EuDES score improvement in the treated group, we obtained in the control group no statistical significance, although I insist, very few cases in the 12-month time point that will need to be accomplished, and therefore we are still pending for the final analysis after 12 weeks. So, as a result of this, what happened to us? In our specific case, I don't know how to tell you, probably we have lost some interest on doing IPLs, but it's definitely a quite feasible treatment that is not has some advantages. So nowadays we are doing 70% less than we did before. And as a emerging option, we need to consider and explore and compare with the established indications, alongside some other emerging options that we use nowadays. And as a summary, it should be applied by an ophthalmologist. The patient identifies the value of her or his doctor to be applying the treatment. It can be done on the go in the same visit without rescheduling. It applies to a wider range when compared to other procedures, and the contactless allow us to reach complex cases of blepharitis in case of need. It's contraindicated in the case of the pacemaker wearers, and its other supportive evidence is yet to come about osmolarity, evolution, some inflammation markers, and the microbiota. Uh, well, we are going to pursue with the treatment over the summertime, and probably we can simplify it by doing less sessions, and still the cost of the platform is only a fraction of the money that we had to pay for the platform of the IPL. Thank you very much for your attention, and I invite you to follow one of our colleagues' presentation in electronic poster in this same meeting. Thank you very much to all.
Thank you very much, Dr. Lapuente, for this very innovative approach. And it's good that there is evidence underway to show whether it's using statistical methods something that is effective or not. But first we have to understand what you really target. I understand that you induce some form of coagulation, and collagen synthesis is a result. But what are really the target cells? Do you target cells of the meibomian glands, so the meibocytes? Do you want to electroporate the meibocytes, or do you target the extracellular matrix cells, such as fibroblasts, which then produce the collagen?
When this technology was given to us, well, it was not given to us. We were early adopters 2 years ago. It was not explained at that time. So we still to have ultimate data of how does it works. I read some of the available information that was given to me by the University of Brno, and they claim to have a plasma thrombotic effect on the dilated vessels around the ducts, and also at the eyelid margin. Now we can see that after their experience in gynecology, they are trying to insist on the effect of the microporation on the cells and allowing the regain of the cell stability by the cell membrane depolarization, repolarization. I would trust that this is, my belief is, I don't believe in the thermal effect. In my experience, I haven't seen any heating of the surfaces that I'm treating, but I think that is the microporation, the new biological effect that accounts for re-equilibrium in the ions, in the different electrical capacities of the cell, and somehow and with other supplementary evidences, they will come to reply in the future, very possibly, as it happened to be with new data on IDPL. So we need to host that new possibility because it's quite simple, it's very cheap. But we need to obviously come back with another supportive evidence of the exact chain that goes along the biological intervention and the final clinical effect.
My presumption would be that you are killing microbes, because plasma is also used to treat microbial keratitis. So that might be an effect too.
Well,
maybe you look.
Well, we should look at the differential microporing thresholds for the microbiotes and see what happens. As you saw in one of the slides, we are going to test what is the influence in the microbiota and the microflora of the conjunctiva and the eyelid margin.
We are running a little bit over in terms of time, but I would like to know whether you've seen any complications. I saw a lot of hemorrhages in the patients treated on the lid margin.
Are you talking about plasma energy?
Yes.
No, Not at all. That is not my experience. If you mean the hemorrhages on the punctures in the cases with a non-contact technique, I can understand, but we have no conjunctival hemorrhages on the plasma delivery. That is not our experience.
Okay, thank you very much.
Thank you very much.
In the chat referring to the last presentation, so I think at this stage we are happy in closing because the next session is coming up. I'd like to thank all the presenters for showing and sharing data and their experience today, and I'm looking forward to meeting everyone in person maybe next year in Paris and then a year later in Düsseldorf. Have a nice time in Paris for now. Thank you very much to everyone. Bye-bye.